Hello again without the echo. I am Molly French, and welcome to A to V, Alzheimer's to Vascular. We are going to go on a public health tour of different types of dementia today. So if you're just joining us, I'm Molly French. I direct the Public Health Department for the Alzheimer's Association, and joined here by John Sheehan, the Associate Director for Public Health. We are grateful. Thank you, CDC, the Centers for Disease Control and Prevention, for enabling us to offer this webinar, which is being recorded so we can share it with others who weren't able to join at this time. But even more, I want to say thank you so much for joining us today. We think we have a great lineup for you, and hope that you'll get a lot of value out of today. As we get started, we do want to get a better sense of our audience, so please complete the poll on the side of your screen. And while that's going on, we're here today because dementia is a single word, but not all types of dementia are the same. And in the same way, shade is just a single word, but with multiple different meanings. When we first bought our home, we had these beautiful big oak trees, and I was so excited. I love gardening. And so summer came, I dashed off to the gardening center, and I headed for the shade perennial section. I got this fantastic collection of plants. I brought them home, and then I planted and watered, and I sat back and I just thought, okay, I'll watch them grow and enjoy them. Well, that was the summer I learned that for a garden to thrive, you have to consider the type of shade that you have. You can't put plants that like wet shade in the dry shade of a maple tree. And plants that need part shade really do need some sun, and they will not prosper if you are offering them dense shade. In a similar way, if we want to optimize the health of older people, including people living with Alzheimer's and other dementias, their functioning, we want caregivers to also thrive, then it's important to know some of the basics about types of dementia for the public health interventions that we develop. After I finish giving you helping set the context for today, we are really excited and pleased to be able to bring to you one of our top experts to help you learn more about different types of dementia. And then Dr. Snyder and I are going to explore what some of the similarities and differences mean among different types of dementia, particularly for traditional public health interventions like risk reduction, promoting early detection, and supporting caregivers. Then the best part, which will be the last 8 to 10 minutes, is your turn. And that's where we really hope early and often you'll be using that question and Q&A function on the side of your screen so that we can better understand what's on your mind. We can be answering your questions again in that last segment of the webinar. Yes. We always get asked and know that we will be sending out slides and the recording next week when they're available. But we will have an evaluation that we will be sending out right after the webinar. And please do take a couple minutes so that we can improve. And now I'm going to just pause and look at the poll results. Okay, so we have about a third of our audience is from public health. Thank you so much for joining us. We have a number of folks from the Aging and Disability Network and community. Thank you. Some healthcare professionals, and then also a number of individuals who are also working on Alzheimer's and other dementias as their primary line of work. Just what is dementia? It's a word we often hear, but sometimes it's not always used well. So in the context of today, dementia is we're referring to an umbrella term, and it refers to a set of symptoms associated with a loss of cognitive functioning that is severe enough to interfere with daily life. Dr. Snyder is going to present on some of the diseases and causes of dementia, which you see under the umbrella, which include Alzheimer's disease. Increasingly, researchers are finding that the majority of cases of dementia are mixed. That means they have more than one cause. So we do have a lot to learn in this area. And increasingly, science is supporting having a robust public health role in terms of the response to Alzheimer's and other dementias. And that's why with the Centers for Disease Control and Prevention and through the Healthy Brain Initiative, we have created a set of roadmaps that provide state and local public health, which you see on the left side, the left roadmap, and Indian country on the right, with a flexible set of expert-guided actions to help you as in the public health field respond to Alzheimer's and other dementias. And these are linked, grounded in the essential public health services so that they can be easily and efficiently integrated into your current portfolio. After today, I want you to come away remembering three things. One, dementia is an umbrella term, and Alzheimer's is the most common cause, followed by vascular dementia. Two, while there are similarities, each type of dementia has distinct characteristics. Three, as you develop public health interventions, when possible, find ways to be responsive to, or at least consider, that there are multiple types of dementia. And this can be done particularly in your work regarding risk reduction, early detection, and caregiver support. We are, again, so thrilled to be able to bring to you one of our top experts from the Alzheimer's Association, Dr. Heather Snyder. She is the Senior Director of Medical and Scientific Operations for the Alzheimer's Association. She oversees the association's initiatives that accelerate innovative Alzheimer's research, and she works very much to provide opportunities for the global dementia community to connect and collaborate. In particular, one of her many responsibilities is serving on the executive team for a study called US Pointer. And this is really applicable to the public health field because it's evaluating whether lifestyle interventions that simultaneously target many risk factors can predict cognitive function in older adults at increased risk for cognitive decline. Dr. Snyder received her PhD in molecular biology from Loyola University, the Chicago Stritch School of Medicine, and she did her postdoc in the neurobiology program at Children's Memorial Research Center, which is affiliated with Northwestern University. Dr. Snyder, welcome. And I'll advance.
Hi there. Can you hear me?
Yes, we can.
Does there sound like there's an echo?
We don't hear an echo, so just proceed. Thank you.
Okay, great. Thank you, everyone. It's a pleasure to be here with all of you to talk about the different types of dementia.
Dr. Snyder, unfortunately now there is an echo. If your computer is also on, you may need to mute the sound coming out of your computer.
Is that better?
Don't hear it now. Go ahead and proceed, and I'll unfortunately interrupt you if it comes back.
Great. Next slide. So when we look at the impact of Alzheimer's and dementia in the United States, we know that there are approximately 5.8 million Americans living with Alzheimer's today. This number is expected to nearly triple to more than 14 million by mid-century if we don't have a way to stop or slow its progression. Next slide. Alzheimer's is the sixth leading cause of death. It is also the only cause of death in the top 10 that we currently don't have a way to stop or slow its progression. Next slide. In addition to the number of people that are affected, there's a tremendous economic cost to caring for individuals with Alzheimer's and other dementias. The cost in 2019 will exceed $290 billion for formal care. So that's not including the unpaid care that many families and individuals participate in for somebody with Alzheimer's or related dementia. These costs are expected to rise to over $1 trillion by mid-century. Next slide. When we think about causes of the cognitive impairment or the memory impairment that is common with dementia, we can think about them as both currently irreversible or potentially reversible. Potentially reversible are often rarer causes. When we think about irreversible, so those that we're not able to turn the tides on, not able to change the direction, we're often thinking about neurodegenerative. So that means that our brain cells, the nerve cells that are selective in the way that our brain is wired for how we think and process information, we see those brain cells dying. Or vascular, so changes in the vascular system, the blood flow, and the overall vasculature of the brain. Next. Examples of neurodegenerative disease includes Alzheimer's disease, Lewy Body disease, frontotemporal disorders, Huntington's disease, Parkinson's disease, and in many individuals with Parkinson's disease, we also see Parkinson's disease dementia, or otherwise known as PDD. Rare causes that may be reversible with intervention might include metabolic dysfunction, tumor lesions, or treating cancer, treating the actual cancer, or medication side effects that an individual may be experiencing, as well as things like alcohol overuse or vitamin deficiencies. Next slide. Many people with dementia also experience behavioral and psychological symptoms. So beyond the challenges with memory, thinking, and reasoning, many individuals also experience things like personality changes, depression, anxiety, delusions, hallucinations, apathy, agitation, sleep disturbances. We hear of people wandering and some of the challenges that experiences. And from a public health perspective, these symptoms and these behaviors are very important to be aware of and to note as we think about interventions and caring for people along the entire spectrum of the disease, whether their symptoms are very mild, so in the earlier stages, or in the more advanced stages of the disease. Next slide. One of the things that I think is really important to note is that the biology impacts behavior. This is a slide that was given to us by Dr. Gil Rabinovich at the University of California, San Francisco. And while what you see here in the color patterns represent some of the hallmark brain changes that we would expect in Alzheimer's disease, and we'll talk in greater detail about that, what you note is that the patterns of where these changes are happening influence the person's behavior. They influence the changes that we see in an individual. And this is the case for different causes of dementia. One of the things that as we understand more about the brain and about dementia and about memory impairment, we also understand that many people have what we would call mixed dementia, meaning that they might have the brain changes associated with Alzheimer's disease, as well as the brain changes associated with vascular disease. And so thinking about what that might mean from a public health perspective, interventions that might be best for those individuals, whether it be medications, lifestyles, or combinations of those interventions, is really important and very much a focus of the research community. Next slide. Diving into the specific types or some of the different types of dementia that we've mentioned, when we talk about Alzheimer's or Alzheimer's dementia, we're often talking about very specific brain changes. This is a degenerative brain disease. As I mentioned at the beginning, this is fatal. We often hear and use terms of Alzheimer's and dementia interchangeably, because it is the most common form of dementia, accounting for about 60 to 80% of individuals. Alzheimer's is a continuum, as we now understand the underlying biology is actually changing a decade or more before someone has the memory changes. And I'll talk through that in greater detail in a moment. Primarily, we associate or think about Alzheimer's disease as a loss of memory, a change in an individual's ability, memory, thinking, and reasoning skills, decline in their overall cognitive abilities that ultimately affects their daily activities. There is a percentage of individuals, approximately 200,000 individuals in the United States today, have what we call younger onset Alzheimer's. So while age is one of the greatest risk factors, with individuals over the age of 65 making up the majority of individuals with Alzheimer's, increasingly we're seeing numbers of people that have what we would call younger onset, meaning that they're developing the symptoms, the memory changes before the age of 65. Next slide. I mentioned Alzheimer's is characterized by very specific brain changes, and you can see those depicted here. What you see is that these neuritic plaques, or as they're referred to as neuritic plaques, they're really clumps of proteins that happen between the brain cells. The primary component of these plaques is a protein known as beta amyloid. We hear a lot about beta amyloid in the news as it relates to Alzheimer's as a possible target for therapy or a target for detecting the earliest brain changes associated with this disease. The other hallmark brain change that we see is what we call tangles or neurofibrillary tangles. And these are inside the brain cells, and the primary component of those are made up of tau, and a specific form of this protein known as tau. When you look under a very high-powered microscope, they look very much like a hair tangle and somewhat of how they got their name. So thinking about these two hallmark brain changes as being associated with Alzheimer's. And then when you look at the brain on a macro scale, what you see here is a healthy brain compared to the side of a brain from an individual with advanced Alzheimer's. And you can see the real changes in the shape and the size, the shrinkage, and that's reflective of the brain cells dying as the disease continues to progress. One of the things to note before moving on is that tau, these tangles that we see in Alzheimer's, are also seen in other diseases like Lewy Body disease, Parkinson's disease, dementia, frontotemporal dementia as well. And one of the key components that's important to note is that it's where those tangles are present that may be related to the specific disease. Slide. I mentioned Alzheimer's disease as a continuum and what that might mean. And that's this idea that an individual from cognitively unimpaired through Alzheimer's dementia may have brain changes that are associated with the disease. You can just fast forward 1 and 2 for the animation. Thank you. Traditionally, we talked about Alzheimer's dementia really based on history and cognition of an individual. And more recently, as the research and tools and technologies have advanced, we have tools called biomarkers, measures of biological change, that allow us to detect these changes in a living person, potentially years or decades prior to someone having memory changes. This opens up the door for us to be thinking about possible prevention, being able to identify someone before they're having memory changes and intervening at that time point. That's very much in the research space, and there are research studies today actively trying to do that. Next slide. As Molly mentioned at the very beginning, probably the second most common type of dementia that we see is vascular dementia. And this is really characterized by impaired judgment or ability to make decisions. Challenges with planning or organizing might be one of the more initial symptoms that an individual may experience. Vascular dementia is really characterized by changes in the blood vessels and the blood flow into the brain. It might be related to strokes or bleeding in the brain. It might be related to other overall vascular health. So you hear about people having mini strokes and those types of things. And that's often characterized with vascular dementia. Using imaging, such as MRI, is a way to detect some of the changes in blood vessels or some of these changes that are characterized in vascular dementia. Many cases when an individual is having cognitive complaints and they go through a workup with their physician, having a picture taken of their brain using MRI is often one of the ways to rule out or to identify whether there are vascular changes that are going on. In terms of some of the science and where we're looking at some of the science, we also know that vascular changes in the brain make an individual more vulnerable to changes that we see in Alzheimer's. And so teasing out whether how the changes in the vascular contributions may impact an individual on their own versus also making them more vulnerable to changes associated with other types of dementia is a challenge. But as we think about therapies and interventions, whether we're talking about medications and lifestyle, understanding those distinctions becomes increasingly important. Next slide. I mentioned at the beginning in terms of thinking about Alzheimer's as age is one of the risk factors that we see, but there's also links to family history, genetics, and some of the environmental and lifestyle factors. Specifically looking at lifestyle factors and really narrowing in on cardiovascular disease, A number of population studies that have looked or tracked people over time have identified that risk factors such as diabetes, midlife hypertension, midlife obesity are linked to greater risk in later life. Smoking has also been linked to greater risk in later life of dementia. The studies don't allow us always to necessarily characterize the type of dementia, but in many cases, these are associated with vascular dementia or vascular related changes. There's also been links to education. Increased education is being linked to reduced risk reduced risk of dementia in later life. And then traumatic brain injury is another risk factor that we see as playing a role, not so much in vascular dementia or Alzheimer's, but in other forms of dementia. And it's been less clear. The studies that have gone on in large populations have suggested this link between individuals that have, for instance, a record of traumatic brain injury in their medical record seem to be at a greater risk in later life. When you look into the biology, what might be happening in those individuals or what's accounting for the cause of dementia, whether it's frontotemporal dementia, Lewy body dementia, Alzheimer's, or vascular, you actually see a mix looking at Lewy body and frontotemporal and vascular as well as Alzheimer's. Next slide. One of the recent studies that reported out is the Sprint Mind study, and you can just advance forward, please. And this study is really was reported out last summer at the Alzheimer's Association's International Conference and published in JAMA earlier this year. And this is really the first study to demonstrate new cases of cognitive impairment. And specifically, in the Sprint study, they were testing individuals, aggressive treatment of systolic blood pressure for individuals. Over 9,000 individuals were part of this intervention that either received this aggressive treatment compared to individuals that did not. And the goal of the aggressive treatment was down to 120, with the idea that after many of you may remember that the Sprint study was actually stopped early because they saw such a benefit on this aggressive treatment for heart health and reducing deaths as a result of this due to heart health as a result of this intervention. However, they continued to follow the participants and evaluate the cognition. After the 5 years, what they saw is 1 in 5 individuals did not develop mild cognitive impairment, which many of us know is really one of these initial brain changes, the initial changes in memory that an individual has before dementia. And when they looked at the combined risk of mild cognitive impairment and dementia, they saw a 15% reduction. And this is incredible in terms of, especially in thinking about from a public health perspective, the potential intervention on vascular risk factors and vascular health and the impact of that on our brain health as we age. Next slide. Another form of dementia that we often hear about or talk about, although it's more rare than Alzheimer's and vascular dementia, is dementia with Lewy bodies or Lewy body dementia or Lewy body disease. Lewy bodies are a specific type of brain change that you can see pictured here. They're really this clump of proteins between brain cells that have this almost halo-like effect. Dementia with Lewy bodies is characterized by memory loss and thinking problems that is similar to Alzheimer's, but individuals may also experience sleep disturbances, hallucinations, slowness, gait imbalance, and potentially some of the Parkinsonism movements that we will see in Parkinson's disease. The primary component of Lewy bodies is a protein known as alpha-synuclein. And as I mentioned previously, we also do see the tau tangles in individuals with dementia with Lewy bodies. Next slide. Frontotemporal dementia is really characterized by changes in personality and behavior for an individual. Difficulty with language can also be a symptom that individuals experience. And again, going back to what we talked about initially is that the biology is really impacting the behavior. And you can see in the picture here, comparing some of the changes that we might expect in Alzheimer's disease versus some of the changes that we might see in frontotemporal dementia. And you can see that the biology of where we're seeing these brain changes is different in the brain, and that's impacting the behavior of the individuals, with the nerve cells really in the front of the brain or the frontal lobe and the side areas of the brain being affected. We'll often see some of the symptoms in the personality changes, language, and ultimately memory changes happen at a slightly younger age. you often see some of these changes happen in individuals around the age of 60. Next slide. You can just click through this. So in looking at other causes of dementia, and I mentioned at the very beginning that mixed dementia is probably one of the more common types that we really see, where you actually see brain changes of the vascular contributions along with Alzheimer's. You might see from an individual that experiences or has Lewy bodies that also has changes that are associated with Alzheimer's. And as we think about interventions, whether it be lifestyle or medication, it's really important for us to have ways to really understand the biology of what's happening in an individual. There's a number of studies and quite a bit of work that's going on to try to be able to measure that in a living individual. You can see other examples here: Creutzfeldt-Jakob disease, normal pressure hydrocephalitis, Huntington's disease, posterior cortical atrophy, Korsakoff syndrome, and then other causes that we mentioned at the very beginning. For more information, just due to time, I'm not going to go through all of these, but for more information, I've included our website here that has quite a bit of information on these different types of dementia or different causes of dementia, as well as what some of the underlying biology might be, and directing to additional resources. Next slide. So thinking about, go back. So in thinking about how the brain changes really define the disease, as we're talking about Alzheimer's disease and related dementia, many of which we've talked about today, whether you're talking about the changes in the accumulation of the beta amyloid in plaques or alpha-synuclein in Lewy bodies, changes in the immune system, and we see inflammation and other changes in the immune system across these neurodegenerative diseases, metabolism, and that's not the metabolism of how you eat, of what you ate for dinner and how your body's metabolizing it quite in the same way. It's more how your brain cells are metabolizing the energy and the food source that it needs for its every process. Vascular disease, really thinking about overall cardiovascular health and how that's influencing our brain health beyond just vascular dementia. How, or more recently, quite a number of headlines on TDP-43 and the potential impact of those brain changes and what that might mean to changes in the brain, or what that might mean to symptoms or to an individual's clinical symptoms as well. Next slide. So as we think about these different brain changes and we think about how to incorporate them and understand them, the ability to measure, and you see here in the blue bubbles, the ability to measure with biomarkers, whether we're talking about imaging, measuring the fluid that our brain is sitting in, the cerebral spinal fluid, whether we're looking at blood, as we see a number of things go forward, or a number of studies go forward with better identifying or developing potential blood tests to detect these changes in living individuals. Saliva tests, looking in our eye as a window into what's happening into our brain. This also opens up the door for us to have targeted therapy and thinking about the different biology and the brain changes, whether you're talking about medication or lifestyle interventions, and more likely combinations of those. Next slide. Because most likely, as we think about effective treatment for all dementia, we're really thinking about lifestyle interventions and medicines and thinking about those in combination depending on where someone is along that continuum. Very much like how we think about cardiovascular disease or heart disease today. Someone may go to their healthcare provider, have high blood pressure or high cholesterol, and based on their age, their intervention may be very different. Maybe a lifestyle intervention and come back in 6 months. It may be a much more intensive follow-up to really understand what's happening in that person. And then medication and lifestyle interventions may be provided, or it may be something much more invasive if they're further along in terms of the underlying biology that's changed. But across that entire continuum, thinking about that same kind of thing for our brain, lifestyle interventions, medicines, and it may depend where someone is along that entire pipeline, but also thinking about prevention. How can we get ahead of those changes in an individual? Next slide. So with that, I'm going to turn it back to you, Molly, as I know we have a few things that we want to discuss.
Yes, thank you so much, Dr. Snyder. And oh my goodness, this is, there's a lot of complexity for us to think about. And then, you know, also not just where we are today, but then also where the science is taking us. So for participants, I want to really encourage you to we definitely want to hear from you. So please use the Q&A function on the side of your screen so that we can get your questions and pose them to Dr. Snyder. We'll be turning that over in a couple minutes. And for now, though, Dr. Snyder and I are going to explore particularly risk reduction a little bit more in depth, early detection and diagnosis and caregiver support. So, Dr. Snyder, as you know, we have the Healthy Brain Initiative roadmaps that I mentioned at the top of the webinar. And these call in particular on public health to help reduce risk for cognitive decline and for dementia. So what are some of the, there's a lot of different modifiable risk factors, but for public health and thinking across the different types of dementia, for public health, what are some of the best opportunities for public health practitioners to be focused on in terms of those risk factors that are modifiable?
Yeah, and I think as I talked about, there are the kind of lists of risk factors that we have hints about. They're linked to increased risk in later life. And of course, although many of us would like to, we can't modify our age or our genetics, at least at this point in time. But in looking at our overall health, things like our vascular health is something that we can certainly be thinking about. The Alzheimer's Association has the 10 Ways to Love Your Brain, which is really looking at the 10 areas that have been implicated in increased risk for cognitive impairment as we age, and thinking about how to or how best to age and be as healthy as we can. So vascular is certainly an area of that. Know your numbers. Have that conversation with your healthcare provider and monitor those numbers and get them under control. And that's true for both cardiovascular, but also metabolic diseases like diabetes, and have that conversation with your healthcare provider. Be physically active, eat a brain healthy or heart healthy diet, which really go again to that vascular component. Reduction of smoking is also very important and is one of the things that we've seen as being linked for later life brain health. Making sure you get a good night's sleep and consistent sleep over time is linked to our brain health, and we see a lot of the connections in the biology. But I would really direct people from the public health perspective to really target into those that are in the vascular area. And again, that's know your numbers, vascular and metabolic disease, smoking, brain healthy or heart healthy diet, being physically active.
Yes, and those are things that's wonderful that we all should be doing individually, but certainly public health departments already are doing work in heart disease and diabetes and tobacco and smoking prevention. So this is an opportunity for them then they can continue working on preventing cardiovascular disease and diabetes and smoking, but then also bringing in brain health elements then into that work. Right now, it sounds like some opportunities. Switching.
Yeah, it's not just about doing those things for our heart health. It's really about doing those for our whole body health, even the neck up.
Yes, even the neck up. I love it. So switching gears over to early detection and diagnosis, which, working here at the Alzheimer's Association for the past 5 years, I know it's very important. Some of our participants may not know, but actually the Medicare annual wellness visit does require physicians to assess cognition. And, one of the pieces in the roadmap calls on public health professionals to be educating the primary care workforce about assessing cognition and early detection. Are there kind of some high-level things that public health should be focused on in terms of promoting early detection among physicians?
And I think one of each year the Alzheimer's Association publishes a report called the Facts and Figures Report, which is really looking at the numbers of people that are affected and living with Alzheimer's and dementia. This past year, one of the special, and each year a part of that report is a special issue or special topic focus on an emerging issue. This past year in 2019, it was a special report on detection in the primary care settings, connecting patients and physicians, and really looking at the importance of early detection and diagnosis for a number of reasons. to ensure that an individual is connected to clinical trials if they're happening, to understand what's happening or changing in themselves, for themselves and for their family, to understand and make plans for their care and their financial future. If it's medication issues or some other cause of the memory changes, to intervene and address those. But I also think that one of the other emerging things that we've seen is the association has been working with a number of stakeholders to develop clinical practice guidelines for primary care physicians primarily and healthcare providers. And there's a number of different tactics, and they're in the process of being published. They've been presented at several large meetings. But one of the big takeaways from those clinical practice guidelines is that if someone complains of a memory change, they should be evaluated. If they are identifying that they see a change in themselves, or their partner is identifying a change, or an informant is identifying a change in them, that should be taken seriously and should be evaluated by the individual. We do recognize that there is a gap in healthcare knowledge, and that's certainly something that we're working to address from the Alzheimer's Association's perspective. And this is a place where public health messaging can really be and play an important role in continuing to raise awareness and raise the importance of early diagnosis and detection.
Yes, and thank you. And I loved your message too about, what we're learning in the clinical practice guidelines that will be published soon are emphasizing is any type of memory change, thinking change merits, that initial discussion with a health professional to get it checked out, and that healthcare providers should be paying attention to that and following up, not just dismissing it. Switching now, in a minute, then we'll go over to Q&A, but thinking about caregivers, and we know, from daily, the number of people who interact with Alzheimer's Association, and just within our own family and friend circles, that many people with dementia do rely on their friends and families to provide care. And the caregivers often want to learn, more about how can they be providing better care, or there's just difficulties that come with those caregiving tasks, and they want to know, is there a way to do this more easily or efficiently, or that's better for the person I'm caring for. So for public health professionals, if they're thinking about caregiver support programs, education, training, some of those parts of those caregiver programs, should they be differentiated for different types of dementia and those specific challenges? What are your thoughts, Dr. Snyder?
Well, I think as we talked about, the behavior impacts the biology impacts the behavior, and many individuals with dementia, regardless of the cause, experience some of the behavioral changes that we started out our time together talking about. I think one of the things that's really important for caregivers, and we certainly work to advocate for linking caregivers to community resources like the Alzheimer's Association, like the Area Agency on Aging, and other caregiver groups in the community, is to always know that you're not alone, and to have those connections and that resource. Individuals that access those types of community resources, they seem to have better outcomes for the caregiver themselves, but also for the individual that's living with or affected by dementia. The Alzheimer's Association has a 24-hour, 7-day-a-week helpline, for instance, that is accessible at all times. I know in our own family, it's been a resource for my in-laws, who are the primary caregiver for our grandmother. And that's something that when she wandered in very cold weather here in Chicago, that afterwards they were trying to figure out how and what they needed to do to make changes in the house. They used the 24-hour helpline to reach out and to get resources. As I mentioned, there are different resources that are within the community, but there are still differences, and that being connected into those resources when your loved one or the individual that you're providing care for with dementia experiences those changes, whether it be sleep or wandering or hallucinations, depending on the cause of dementia. If you're connected into those resources, they can really help you address those changes. I heard from a gentleman once in Florida that talked about how his mother wouldn't shower, and that for him, that was a significant behavioral issue that he had to deal with her on. And so he had reached out and had talked to somebody, and they talked through a number of scenarios, and eventually they came to the idea that she liked VO5 shampoo, for anyone that might remember that. And so he would buy the VO5 shampoo and tell her that it had special ingredients in it. And that seemed to get her in the shower. But it was really being connected into the community resources already that when he was dealing with that behavioral challenge, he was able to get personalized and focused advice on how to deal with that. And I think that's one of the key things that as a caregiver goes through the process, really being aware of the community resources that are available and that are out there, and helping to make sure that they're as easily available and accessible to caregivers is important. I do see that one of the questions that came through, and I'm just going to tie this into this part of the conversation, was around some of the public health implications for caregivers, as well as those for dementia. And I think that could be a whole other webinar as we think about the physical health, the psychosocial implications, and overall challenges for caregivers, because we do know that many times caregivers are so focused or dealing with all of the challenges of providing care that they don't necessarily take care of themselves. And that's really, again, where being connected to the community resources is so important, whether there's caregiver support that really encourage and support and look for those stressors or look for those links that will be supportive of the caregivers is so important. In terms of specific guidelines for primary care, for screening and treating caregivers, I don't think that's not something that exists today. And in fact, the clinical practice guidelines that I mentioned, which are being published, are actually the first type of guidelines ever for thinking about cognitive impairment and dementia in clinical care beyond what's been developed previously for specialists. So just to put that into context.
Perfect. And, you touched on so many wonderful pieces, and public health has a great role in terms of just helping raise awareness among caregivers about what is accessible in their community. And you also touched on, but I want to make sure our participants understand that the Alzheimer's Association, while we certainly specialize in Alzheimer's, we have a lot of depth and breadth across different types of dementias, and really want to serve everybody, including through our 24/7 helpline. I'm going to switch I'm so glad you just segued perfectly into the Q&A. And we have time for another question, which was, wondering how should we as public health professionals be coaching or educating primary care providers about risk reduction?
Yeah, I think that's really important as we think about making sure that primary health care providers have the information to have that conversation about not just cardiovascular health, but actually the impact on brain health. I mentioned the 10 ways to love your brain, but I think there's also tools and resources that maybe Molly, you can speak a little bit to as well, that primary care physicians can access, and there are different toolkits and other resources that help to support that conversation for primary health care providers with their patients.
Excellent. And that I'm going to just flip ahead and mention that we do have a website, alz.org/public health, where participants can access the roadmap. You can get more information and resources, whether it's on brain health risk reduction, early detection, diagnosis, and a lot of other pieces. We also have data and a lot of examples and tools that public health can be using. I'm going to be mindful of the time and close with a reminder, recap of our primary takeaways from this webinar, which are threefold. First, that dementia is an umbrella term. Alzheimer's and other dementias are the most common cause of dementia. That's followed by vascular dementia, and we are understanding more and more that most brains have mixed dementia. And while there are certainly similarities, for example, the loss of cognitive functioning and impact on daily life across dementias, each type of dementia has some distinct characteristics, and I hope from Dr. Snyder, she kind of whets your appetite to learn more about each of these. And then third, as you're developing public health interventions, please use the roadmaps for guidance and find ways, when possible, to develop those robust public health interventions keeping in mind that there are multiple types of dementias, multiple populations to be serving. I do want to say thank you so much, Dr. Snyder, for carving out time to tell us more. And also to our audience, thank you so much for going on our quick public health tour. We will be sending out an evaluation, or you can just use the bit.ly short URL there to jump to it right away. We do really care about what your opinions are so that we can keep improving and offering really helpful webinars for you. And already had a great suggestion from our participants, so thank you. Next week, we will be sending out to everyone the slides as well as a recording and a couple other suggestions. In the meantime, you can go to alz.org/public health, or we also highly recommend you check out cdc.gov/aging. Thank you all so much for joining us. Have a great rest of your day. Bye-bye.